Our next speaker is Dr. Yasser Masood. He is graduate of King Edward Medical College. He is FCPS from Children's Hospital Lahore. Then he completed his CCT from UK, and now he is working as consultant pediatrician at Shifa International Hospital.
Patients, but there will be some children coming to your practice as well. So a major problem in pediatric asthma is incorrect diagnosis, overdiagnosis and delayed diagnosis. We still have many children who are not being either diagnosed with asthma or not properly managed, or they are being overdiagnosed and being put on asthma medications when they actually do not have an asthma and probably do have another underlying problem. So that is one of the major challenges that we face. Another important aspect of pediatric asthma in Pakistan is lack of proper education and training of parents. We know that majority of our parents, especially in the rural communities, because of the lack of education and lack of access to the healthcare facilities, they are not adequately educated, so the long-term management of these children is not optimal. There are obviously compliance issues and technique issues there. We know that the inhaler use is all dependent upon how adequately the inhalers are used, especially in children. And if there are issues with compliance and inhaler technique, these children are going to be undertreated and are going to have persistent symptoms. Another major issue that we face here in Pakistan is the lack of availability of suitable inhalers. We shouldn't really be talking this in 2024, but believe me that at the moment in Pakistan we hardly have any suitable inhalers for children. Most of the inhalers that we have to use even in young children are those which are basically adult preparations. So even the pharmaceutical companies, I don't know what is the reason, they are not making products which are suitable for children. And also there are no regional or national guidelines on the management of asthma. That is one of the factors. So what we will discuss in today is that how asthma presents in children, how do we diagnose, and what is the current evidence-based management. I will again refer to the GINA guidelines. There are different guidelines. There are NICE guidelines, SIGN guidelines, American Academy of Pediatric guidelines. But I think probably the GINA guidelines are the ones which are more comprehensive and mostly used by the health professionals. So the clinical presentation in children again depends upon the age, and the commonest presentation in children, especially in young children under the age of 5, is that they have viral upper respiratory infection associated with these. Now these children may or may not develop asthma as they grow older, but whenever they have a viral infection like rhinoviruses or adenovirus, they will then develop wheeze and will present like an attack of asthma. So that's one of the commonest presentation in young children. Then there's another group of children who have allergic sensitization to a variety of allergens, and they then develop symptoms of bronchospasm. These allergens are house dust mite, animal dander, exposure to smoke, pollens, grass, weeds, mold or damp in the house, and a variety of chemical irritants. So any of these allergens, if present in the environment or in the household, will contribute to allergic sensitization in children who are predisposed to develop asthma. So cough is the commonest presentation in children, and wheeze again either associated with viral upper respiratory infections or on its own. Then there are seasonal symptoms like allergic rhinitis, allergic conjunctivitis, especially in this area where the pollen count is high. We see a lot of children with rhinitis and conjunctivitis and exacerbation of the wheeze. Most of these children will have some atopic background, so they will have eczema, dry skin, and then there are some older children who have exercise-induced symptoms. So they may not have any of the symptoms otherwise, but whenever they are playing or running around, they will get breathless and then they will have bronchospasm. In terms of diagnosis, again, as Dr. Ryan mentioned in his talk as well, that the diagnosis is not very easy, it's not straightforward, and again, the 4 things that he mentioned in his talk, again applicable to the children as well, that what we need is a very good history, a good physical examination, some tests in selected cases, and evidence of response to the treatment. So these are the things that we need in children to make a diagnosis of asthma. So again, the good history is very important. The symptoms have to be consistent with an allergic sensitization and wheeze. It is important to ask that what are the triggers which contribute to the symptoms and atopic background. And again, for the physical examination, the problem with the physical examination is that it is possible that if you're seeing the children in the clinic setting, when they're coming to the clinic, their chest may be completely clear. So again, repeated consultations or repeated examinations is important in establishing the diagnosis. Sometimes if they're presenting to the ER, emergency department, if with acute exacerbation, it's probably easier to make a diagnosis in that setting because at that point they will have clinical examination consistent with asthma. Again, chest X-ray is not required in all the cases, but those children who have recurrent presentations, chest X-ray is essential, especially in younger children, just to make sure that they do not have any underlying congenital abnormality, which is presenting as asthma or wheeze. We have seen children with, especially with congenital diaphragmatic hernia and some congenital lung malformations, who continue to present with viral upper respiratory infections or wheeze, and then actually have an underlying congenital abnormality. Now, the response to therapy again is very important. That if we're giving the bronchodilators, there should be response, and the cough should get better, the airways should open up. And objective tests like peak expiratory flow rate and spirometry is available more in the older children because it's difficult to perform in younger children. And again, not required in all the cases. If the history and physical examination is fairly consistent with the diagnosis and they have responded to the therapy, these tests may not be required. If we're dealing with children who have difficulty to control asthma despite good compliance and despite good medications, then in those cases the skin prick testing against allergens and specific IgE testing, which is called RAS testing, that would be helpful, especially in those cases who are resistant to treatment or moving towards the severe end of the spectrum. Now, moving on to the management, I'll briefly touch that how we manage children with bronchial asthma. The management is different in those who are under 5 and those who are over 5. So, under 5 is generally we don't tend to label asthma in very young children because most of these children are having viral-induced wheeze. So, in the acute episode, the treatment is inhaled short-acting beta agonist. Again, I think in Pakistan the nebulizers are used much more than they are really required. So actually the inhaled therapy is as good as nebulized therapy, and as pediatricians I think we need to work more in educating the parents that actually the inhaled therapy is much more effective than the nebulized therapy, and you're giving a much lesser dose of especially steroids if you're using the inhalers. So the inhaled short-acting beta agonist in the acute phase of viral-induced wheeze is on its own is enough in most cases. Now, we talked about the steroids at the beginning of the session. So only those cases who are having severe attacks of viral-induced wheeze, only those children will need oral steroids for a period of 3 days. And we try not to use them very often. And if the children are needing repeated courses of steroids, then these are the cases where we'll put them on controller therapy so that the need for these courses of systemic steroid is reduced. So in terms of the controller therapy in these children who are having recurrent viral-induced wheeze and are needing repeated courses of steroids, you can start them on very low dose inhaled corticosteroids or leukotriene antagonists like montelukast, and then you can move on to the step 2 and 3 if needed. You can go on to the low dose inhaled corticosteroids with LTRA, and in those cases who still continue to have symptoms, you can double the daily dose inhaled corticosteroids along with LTRA. But another important thing is that those children who are having recurrent viral-induced wheeze, another strategy that can be used is that as soon as they start developing symptoms of a viral upper respiratory infection, a 5 to 10 day course of inhaled corticosteroids is useful in reducing the severity of that attack and reducing the need for oral or systemic steroids. The daily montelukast is not routinely used and is again the GINA guidelines do not recommend, but in those cases who fail to respond to inhaled corticosteroids, they can be tried on daily montelukast. As I said, it's better to use inhalers rather than nebulizers. For young children, obviously, it is difficult to give the inhaler by itself, so a spacer and face mask should be used. So this is, I hope that most of you have seen these. I tend to use this almost in every patient I see with viral-induced wheeze or asthma. This is the spacer, that's the inhaler. The face mask is used for very young children, but again, the supply of the face mask is intermittent. Sometimes we get them, sometimes we don't. So especially for children under the age of 2, it becomes very difficult how to give them inhalers. So ultimately we have to resort to to the nebulized therapy. In the UK, these things were very easily available, so we hardly needed to use nebulizers in young children, even with acute exacerbations. So the choice of the inhaler depends upon the specific needs of the child. The most important thing in the management is teaching the parents that how to use the inhaler and how to use the spacer. And I always refer my patients to the YouTube because there are lots of good educational videos on the YouTube that how to use the inhalers and how to use the spacer for the young children when we're giving them the steroid inhalers or bronchodilators. In terms of the management over the age of 5 years, I'm not going to go into the details, but this is essentially what Gina is recommending in a stepwise fashion, and that's starting off with short-acting beta agonist along with low-dose inhaled corticosteroids. We slowly move up on the ladder from low dose to medium dose to high dose inhaled corticosteroids along with a long-acting beta agonist. One thing which is important, you will not see LDRA on this slide now. And those cases who have severe uncontrolled asthma, those are the ones where immunotherapy is needed, and these are the ones where we will ask for specialist advice. This is from, again, 2023 GINA guidelines. What exactly has been discussed earlier in the talk as well, probably more or less in the same fashion that you start off with low dose inhaled corticosteroids and move up to step 4 in a gradual fashion and add on LAPA as needed. I think in children, because we are very concerned about the side effects of the steroids, because this is their period of rapid growth, so it's very important to be very careful that how much inhaled corticosteroids are being used. As I said, if you're giving nebulized therapy, they're getting a lot of steroids, so you have to be very careful of the side effects. For young children, we do not need more than 50 to 100 microgram per day. But the problem in Pakistan is that we do not have these inhalers available in this strength. So the lowest strength that we have available is 250 microgram metronidazole. So these are the different inhalers that are used in pediatrics. Sadly, in the UK we had 50 microgram clandles, which was very easy to use. But in Pakistan, that's the lowest that we have used. So even our young children, when they're getting steroid, they're at least getting 250 microgram daily, which they would not need if the shorter dose clandle was available. This is obviously, seretide with fluticasone and solmetrol, and Xeritide is again a good combination because it has both short-acting beta agonist and steroid as well. I'm not going to go into the details of biological agents, but again, they are used in children over the age of 6 years in those where the asthma has been very difficult to treat and resistant to treatment. So, in the end, I think the important message from the GINA latest guidelines is that they do not recommend now, just like in adults, that do not use short-acting beta agonist on its own in children over the age of 5 years. And whenever they're needing short-acting beta agonists, they should be used along with inhaled corticosteroids. And that has been shown to prove that that reduces the incidence of ER attendance and reduces the incidence of severe attacks, and also reduces asthma-related deaths. Thank you. If there are any questions.